Hello, my name is Ken Herrmann. I'm a nuclear medicine physician in Essen, Germany, and I welcome you to the podcast number 4 of the Journal of Nuclear Medicine. The topic, I think, is a very timely, very important topic, is how radiopharmaceutical therapy reshapes the prostate cancer landscape. And I have two outstanding guests. They actually do not need any introduction. I will nevertheless do so. The first one is my co-moderator, Professor Dr. Heiko Schoder, who is the Chief of Molecular Imaging and Therapy Service at Memorial Sloan Kettering Cancer Center in New York. Welcome, Heiko.
Thank you.
And the second one, the candidate who we're going to quiz today, is a board-certified medical oncologist, Michael Morris. He's also the prostate cancer section head of the geo-oncology team, and he's also the Stephen A. Greenberg Chair in Prostate Cancer Research, and as I said before, very well known in the field of prostate cancer and prostate cancer research. Heiko, I think we start off, we know that one of the most important topics, the most landscape-changing topics in nuclear medicine was the VISION trial. We have the great pleasure to talk to one of the godfathers of the VISION trial. Mike, tell us a little bit how we got there.
Well, the VISION trial is, I think, a really seminal study. Not that it may be the greatest manifestation of radiopharmaceuticals that will ultimately play out in prostate cancer, but for the field, it was the first phase 3 tumor-directed radiopharmaceutical study that really paved the way to open the field up to radiopharmaceuticals that targeted the tumor as opposed to our prior bone-seeking radiopharmaceuticals in prostate cancer. And in terms of influence, you know, when radium was approved for prostate cancer, it was a one-drug approval, and it didn't really transform the field. But the introduction of lutetium PSMA-directed therapy has really changed the field. It's opened up a host of other registration studies in prostate cancer to move radiopharmaceuticals from the last phases of the disease to earlier, opened up new companies, lots of participation globally of a new field of study in prostate cancer. And now we're, moving on to second generation compounds with actinium, lead, and moving from betas to alphas. So it's a really important study historically, if not for bringing a new standard of care to prostate cancer as well.
So, Mike, just to sidetrack for a moment, is there still a role for radium-223 in the era of PSMA?
That's a great question. I think we'd all like to know the answer to that as well. I think that there probably is. If you look at radium, it's an awfully well-tolerated drug, especially from a marrow perspective. So if you had, for example, a patient who had bone-dominant disease with fragile marrow, I think it's a really perfectly legitimate place to put radium-223. I also think that there are combination studies that are still ongoing with radium. So not to serve my own purposes, but one of those is a trial that we lead, which is radium with chemotherapy plus or minus radium. It's called the DORA trial. It's an international study. So if radium proves to be an important adjunct to chemotherapy, then it has sort of new life as well, again, in bone-dominant patients. So I think that there is plenty of sort of opportunity to explore the uses of radium, but realistically, it's going to be in the interstices of a tumor-directed world. So there are, of course, alpha and beta strategies of tumor and bone-seeking radiopharmaceuticals, but I do think that we're undergoing a sea change into tumor-directed therapy as opposed to bone-directed therapy.
Following up on VISION, Pluvicto is approved in the US, also in Europe. So we know that there were certain difficulties in getting access to Pluvicto once it was approved. How is the situation now? Do you get enough Pluvicto for your patients?
We do, but I think that there's a lesson to be learned there for the field. There are two lessons, really. The first, and there were two hurdles. One was the actual conduct of VISION. Remember that VISION had to be stopped after the first few hundred patients because of a 50% drop-off rate in the control arm. So that was a very educational experience in terms of how these trials were going to be done in a multidisciplinary manner internationally, such that, everybody, all of the fields were equal participants. I know that there is sort of like word out on the street that the reason for that dropout was that the control arm didn't have chemotherapy. It's not that it didn't have chemotherapy, it's that it didn't have Pluvicto, right? That was the disappointing thing. But also, it was that, there wasn't an adequate education level, an integration level, and a trial that clearly needed multidisciplinary engagement on a site basis with experienced investigators in multiple disciplines, because those patients did need both nuclear medicine and medical oncology. And I think that lesson was learned with Vision. And the second thing is that going into radiopharmaceuticals is not the same as going into making, let's say, another oral hormonal therapy. There's a whole manufacturing component that has to be in place as well, and the logistics of that. And that can be underestimated. In today's day and age, we hear of a very big company buying a small radiopharmaceutical company like once a month. But what needs to be appreciated is not just a big fish eating a little fish. There's a whole operational aspect, logistical aspect, drug delivery aspect that needs to be learned. And I hope that many of those acquisitions have looked back at the experience with Pluvicto and learned a certain lesson that you need the vertical production capacity. You're not just buying an asset, but you need to learn. You have to also have the manufacturing and distribution in place as well. So that was a pretty eye-opening experience. But what is extraordinary is that from a patient perspective, the desire to get radiopharmaceutical therapy is so high that it's still worth the while for many companies to assume that logistical burden. I mean, we're not talking about a small amount of resources that's needed to acquire a radiopharmaceutical asset, but really demand is very significant. And as we think about where radiopharmaceuticals could go, I think that patient demand will be even higher.
So, Michael, speaking of patient population, let's talk briefly about expanded indications beyond the post-chemotherapy setting. So let's assume, just to name two trials, PSMA addition and PSMA4 are going to be successful. What's your estimate, let's say, for North America in terms of the potential patient population, like in a multiple of the current population, what we could expect?
Let's talk about PSMA4 for just a second, because I think that that's really on the tip of everyone's tongue as the data is really rolling out in real time. I think people will see some new data at ASCO, which is just coming up very shortly, at SNMMI as well, and then there's some new data that's planned for ESMO too. But first of all, I would say that from a primary endpoint perspective, PSMA4 is a successful trial. Its primary endpoint was radiographic progression-free survival, and it delayed rPFS by 60%. The hazard ratio was 0.41 in favor of lutetium. And the control arm for that, just to go back for a minute, in case anybody doesn't know who's watching, this was a patient population who had been treated with and progressed through one ARPI. So there could be enzalutamide or abiraterone as a most common use. And they were randomized to either the alternative ARPI or to lutetium. rPFS was the primary endpoint, and quality of life, response rate, PSA decline, and overall survival were only some of many secondary endpoints. So what PSMA4 did show is that it prolonged rPFS, prolonged the time to a symptomatic skeletal event, and prolonged the durability of remaining pain-free, and as well the QOL assessments better than the ARPI, and it was more tolerable than the ARPI. If you look at the dose adjustments in the lutetium arm, only 3.5% of patients needed a dose adjustment for tox in the PSMA in the lutetium arm, whereas 15% needed an adjustment of dose in the ARPI arm. So you had better disease control, quality of life preservation, with a drug that was better tolerated in favor of lutetium. What we didn't know was overall survival, and that needed to be supported. The data that were originally presented by Oliver Sartor at ESMO last year were based on only 45% of the anticipated death events, and that was with a hazard ratio of 1.16. We now have 75% of those anticipated death events, and the hazard ratio, as you know from a press release that was required, is less than 1, and the actual number will be presented by Karim Fizazi in about 2 weeks. So I think that the trial works, has shown that lutetium does work.
So, Mike, this is a very important topic, and the majority of our listeners are nuclear medicine physicians, so help us understand. The hazard ratio for overall survival, if it's like 1.03, and on the other side it's 0.98 as an example, is from the confidence interval not really different, right? But from a regulatory perspective, it might be very different. Can you help us and tell us why this is the case?
Sure. So, Ken, you're absolutely right. In terms of your confidence of the number as to whether it is 1, slightly above 1, or slightly below 1, these are all falling within the same confidence interval that straddles 1. However, from an approval point of view, it's hard to approve a drug that may have a survival deficit, and that you can't say we have a hazard ratio as a point value that is 1 or less. But I think the other thing, Ken, which should be pointed out is, are we approving drugs that are just the same in terms of OS now? I mean, that indeed is a good question. Traditionally in oncology, we usually do studies that show an improvement in OS. And there are a couple of things that interfere with that in this trial. The first is that this trial permitted a crossover. So if you were originally on the second-line ARPI arm, and you radiographically progressed and met the primary endpoint of the trial, you were permitted to cross over and receive lutetium. And as the data that were originally presented at ESMO last year, 84% of the patients crossed over. It's an extraordinarily high number, which makes the trial really one of lutetium now versus lutetium later. So that's a really important point to understand. The second is that from a patient perspective, if you can live better and have more durable treatment and have treatment that's less toxic, even if you live just as long, that's a win for a patient. That's a clinical win. So we have to understand what the real question is in terms of clinical context, and what the numbers and the design are to explain why the hazard ratio might be at about 1.
Let me like back to my original question about your estimate about the patient population that will undergo PSMA treatment in one form or another. Let's assume with these new trials, either alone or in combination.
Yeah.
Are your best estimate?
I think that radiopharmaceuticals, like almost all therapies, will do better in earlier patients. Why? Because patients earlier in the natural history of the disease are healthier, they have a lesser disease burden, and they have far less heterogeneity and resistance mechanisms. Those are the 3 kings of determination of whether a therapy is going to be effective or not. And I think that we have seen in so many disease classes that earlier therapy yields superior results relative to treating patients at the end phases of the disease, that one would expect that to be true of radiopharmaceuticals as well. Now, you could say, well, with radium, we couldn't go earlier because of an increase in the fracture rate, but that was because we didn't appreciate the importance of bone protection with the use of either Zometa or denosumab to prevent those fractures. But I do think that radiopharmaceuticals can and should be moved earlier. The question is what are the risks of doing so? So there are some risks, like a risk of second malignancies, because most patients at the end phases of the disease aren't going to have time to develop those. And the risk of late toxicity, because again, patients treated late don't live long enough generally. Remember that the median overall survival for vision was only 12 it was only, 15 months. And median overall survival for PSMA4 is 19 months. But as you move earlier, now overall survival is going to be measured in years. So those need to be seen, those need to be attended to, those risks. And we have to think about candidacy for future therapy down the line as well, right? So if the patient does relapse, will they be fit enough to receive additional lines of life-prolonging treatment? But I do believe, as I think do most people, that what has been shown in the past will be predictive of the future as well, that earlier therapy is better. Whether that's as a single agent or in combination will be determined to a large degree on the patient and the complexity of their disease. Would it be nice to be able to replace hormonal therapy with radiopharmaceuticals from a patient perspective? Absolutely. Right? I know of no patient that says, I would like to have castrate levels of testosterone. That would be wonderful. But we are dealing with a heterogeneous disease, and the complexity of the tumor biology and also the nature of the radioligand. If we go to alphas, we aren't necessarily hitting non-PSMA expressing cells that may be deeper in the tumor bed. And so it may be that we need combinations to increase PSMA expression, sort of like Enza-P did in the castration-resistant setting, in order to maximize this therapy. I would think we would, but there's always the hope that it will have a replacement rather than an additive role.
So we talked about vision, we talked about PSMA4, PSMA addition. This all includes PSMA 617. Now there's more in the PSMA space. Would you like to talk very quickly about J591 and PSMA-INT?
Sure. So let's talk about, since we were talking about PSMA4, we can talk about SPLASH if you'd like, which I think does. So SPLASH resulted again by press release, and so we don't know the full details. But the thing about SPLASH was it used also a lutetium small molecule that targeted PSMA, but the dose and dosing frequency was lesser. It used 6.8 instead of a dose of 7.4, and it was given every 8 weeks rather than every 6, and was given for a total of 4 doses rather than a maximum of 6. So the dose intensity and the total exposure was lesser, and you saw a lesser treatment effect in terms of the overall duration of effect in terms of RPFS and maintenance of being disease-free. So I think that does speak to the importance of dose or activity in this disease. I think that we'll have to look at those data when they're really open for peer review, because one thing to pay attention to in that press release is that the control arm also looked like it did more favorably from a toxicity standpoint, not just the treatment arm. And you would think if these were identical populations, the control arm of PSMA4 and the control arm of the control arm of SPLASH and the PSMA4 control arms would look similar in terms of a toxicity profile, but they don't look quite similar. So there may be differences in the population, not just differences in the dose. There is a third candidate in that space as well, which we are still waiting for data. So there could be 3 different drug products in that pre-chemotherapy space. And then as we look forward, there are, of course, the alphas to fully develop, and we need to consider those questions that Heiko, you were just asking in terms of what clinical context, what do we need to be worried about in terms of downstream side effects and limitations, but also the enormous opportunity as you move early to really achieve some disease eradication, if not, or really durable responses as well. So I think this is an incredibly exciting time as we think about moving into the alphas and other radioligands as well. There are other targets too, Ken, and that is, for example, HK2, which is a target near and dear to our heart at MSK because much of that work came out of MSK's labs, both preclinically and in terms of designing the drugs that ultimately are being used. We're going to present that early phase 1 study with actinium at ASCO in just a couple of weeks as a mini oral presentation. But I would say it's looking quite good. And other targets as well for the neuroendocrine prostate cancer patient, delta-like ligand 3 or DLL3, also which we are developing here at MSK. Looks really, really promising in terms of a new way of treating an otherwise untreatable condition, and that is the treatment-emergent neuroendocrine prostate cancer patient.
So, Michael, we talk a lot about radiopharmaceuticals, and that's the target audience, but we have to be cognizant that there's many, many other drugs out there. So if you could briefly maybe try to put things in perspective vis-a-vis antibody drug conjugates, bispecific, antibodies, and even maybe one or two sentences on CAR T cells. Are they dead in prostate or
Sure.
what's going on?
Let's start with one of the most promising, which are the bispecific antibodies. So that just for an audience that may not be familiar with them, these have on one end a target that's tumor specific, and on the other that is usually, well, it's T cell specific, but frequently CD3. And so basically the idea is to bring the tumor in close proximity with the T cell and then activate the T cell basically. These drugs can cause significant autoimmune phenomena, especially CRS or cytokine release syndrome. However, with the experience of developing these over time, we're getting pretty good at managing CRS and also dosing schedules and mitigation strategies that reduce CRS. And what we're seeing is with some of these drugs, real efficacy like we haven't seen before. The most prominent of those right now is probably a bispecific antibody that targets STEAP1 that really had remarkable responses in both bone and in liver in its early phase study that was presented by Kevin Kelly at ESMO. And this, of course, raises an interesting question for those of us who investigate radiopharmaceuticals, whether STEAP1 could be a good theranostic target. I personally think absolutely, and we had credentialed the imaging of STEAP1 a number of years ago here at MSK as well. And then in terms of CAR Ts, I don't think CAR Ts are dead in prostate cancer, and the appeal is so great of having the patient be their own pharmaceutical manufacturing facility. So the patient is the therapy, and as a sort of having a one and done treatment philosophy where you just create the environment for the patient to produce their own immune response against the tumor. But the thing is that unlike some other malignancies, prostate cancer, the side effect and risk profile has been higher than the gain that's been seen. And in a treatment strategy which isn't aiming for cure or even durable remission, or it's aiming for those but just not achieving them, that risk to benefit ratio has to date been unacceptable. But I think that we are seeing in both of these drug classes a new breath of life in immunotherapy for prostate cancer, especially with the T-cell engagers, because remember, there's just not much role for traditional checkpoint inhibitors in prostate cancer, except for those MSI high patients, which is only around 3% of prostate cancer. So these drug classes have shown activity, and it's just a question of getting a handle on the immune activity and the immune stimulation without sacrificing any of the efficacy. Ken, you asked about ADCs as well, I think. So ADCs, we in the prostate world are looking with great envy at our breast cancer colleagues at the success of ADCs in terms of targeting TROP2, B7H3 we have envy for as well. You know, we also have a long history of ADCs targeting PSMA, and whether it was an issue of the linker or not having the right payload, it wasn't until really theranostics that PSMA-directed therapy was a winner. And what we have to see is in today's day and age, do ADCs have activity in prostate cancer with today's linkers and today's payloads that are non-theranostic? B7H3 and TROP2 may be expressed in metastatic disease, but we have a very heterogeneous disease, and it's a question of really identifying those folks who would benefit, which still brings in the need for imaging predictive biomarkers. You know, you never really, even in the other targeted therapies that don't involve radiation, I believe personally that the prostate cancer is heterogeneous enough that the role of imaging and identifying candidacy for even non-radiopharmaceuticals is really important and should be done.
This is a fantastic discussion, but time is flying. That's why I have two more questions to ask
Sure.
you. One of them is patient selection. PSMA, PET, FDG, yes, no, both?
So I think that what I'd really like to see before I were to say yes to dual imaging and the expense, and I recognize that in the American health care system, expense is a significant thing, and that may not be true of all healthcare systems. But I really want to see a true benefit, not just in terms of response, but in terms of more definitive patient outcomes, that using dual imaging agents yields better survival. And, you know, without a head-to-head comparison, I think that it's going to be difficult to prove that point. I think that, you know, the use of dual imaging does create a data that would suggest that you are having a more relevant PSA response rate. So if you look at, for example, therapy versus vision, maybe it does induce a greater response rate from PSA, but you want something a little bit more clinically significant than that. There's certainly a role for dual imaging in the neuroendocrine or the poorly differentiated patient population to understand those patients and try and figure out, you know, what's actually driving the survival limiting disease in those patients. But as a routine issue, should we take all of the vision patients and dual scan them? I don't have the evidence right now that will improve patient outcome.
Super. And the second question is, of course, an important topic, assessing response to treatment. You're also the driver of PCWG3. PCWG4 is coming. Don't tell us any details, but there's a certain difference between assessing response to treatment in clinical trials versus clinical reality. I would like to have your comments on this as well.
The main challenge in terms of working group 4 is contending with PSMA PET imaging, which we would love to have a direct assessment of distribution of disease and response to therapy, which right now bone scintigraphy or CT really don't afford us, especially with bone-based metastases. And PSMA PET imaging has the potential to image directly the disease. The confounder, of course, is that PSMA itself is frequently regulated by the target of therapy, which is hormonal therapy in large part. And so you could have both PSMA flares and PSMA, especially castration-sensitive disease, PSMA downregulation as well in response to AR-directed therapy. So I think that we're going to need to deal with, in working group 4, a system for studying PSMA PET as a response measure, disease context by context, and therapeutic class by therapeutic class. Now, we also need to figure out a way that we can have a universal method of measuring those changes that's available to everybody. So as you well know, RECIP looks at changes in volume of disease. PPP looks at new lesions as a measure of progression. We're going to have to really have a period of testing all of these as what the best way of both looking at response and progression is, having data to support that, show that there is a correlation between those changes and outcome before we can really say we have a handle on how to use PSMA PET as an indicator. We did this between working group 2 and working group 3 with what we used to call conventional imaging. We had a period of just data collection, and then we could go back and say these hypotheses were right and these were wrong. We're going to have to do that again. We have to reset the clock.
So, Mike, a very fascinating conversation. I think you will agree. But in respect to the audience, I think we're gonna come to a conclusion here. If you could give us your outlook regarding the role of radiopharmaceuticals in 2035, and I want to expand a little bit. Is every patient with metastatic disease going to undergo genomic testing? Along the same lines.
Sure. So every patient now with metastatic disease should be undergoing genomic testing, and if they're not, then they're being underserved. So we should have a genomic categorization of everyone who undergoes radiopharmaceuticals by virtue of their being eligible or not for other drug classes anyway, like PARP inhibitors or immunotherapy. If you look to 2025, I think that we will 2035. Yeah. So I think we will in 2035 have a much better understanding of the actual biologic characterization, not the genomic characterization, but we should be able to see phenotypically, instead of saying you have neuroendocrine prostate cancer or you have an HRD tumor. For so many disease classes, we should be able to describe disease by the target. So, PSMA positive disease or STEAP1 or STEAP2 or TROP2 or B7H3 or HK2 positive disease. And that will actually have meaning in terms of treatment selection. By 2035, I would hope that we have gotten past the uncertainties about the issue of long-term toxicity. And we should also have gotten past the fact that we hold radiopharmaceuticals to a different standard than every other anti-cancer drug, that we can't see long-term toxicity. We should be able to accept that with enough benefit. We accept that for chemotherapy and PARP inhibitors. We know that these patients, some will die from treatment, some will develop second malignancies from treatment. It's going to be true for radiopharmaceuticals as well. By 2035, we should certainly accept that and see that it's low enough such that the benefits well outweigh the risks. And we should have combinations that are rational based on our knowledge of the disease. 2035 is a long way away. Think of how much has been done in just the last 10 years. And another 10, I think hopefully we really won't recognize today's landscape in another 10 years.
This is a wonderful ending. Mike, Heiko, I really enjoyed this discussion. It's wonderful. It's a promise and a threat at the same time. I will definitely invite you back before 2035. Thank you very much.
Thank you very much.
Please enjoy, audience, this wonderful podcast. Thank you.
Thank you. Ken, Heiko, it's a pleasure. Thank you for having me.
Thanks for talking to us.